So this is Lackawanna County Medical Society's Public Health Education Series, number 5, and it is "The Drug Problem Lurking in Your Home" is the title. We have Dr. William Dempsey, who practices family medicine. However, he is an emergency room physician many years before that, and he is doing a wonderful job at the Wright Center in Education, and we're happy to have him. He knows a lot about this, and happy to have him here on the panel tonight. And also we have Scott Constantini, who is the Director of Behavioral Health, both of them at the Wright Center for Graduate Medical Education. Scott has been doing this and in the behavioral health field for over 20 years, so he brings a wealth of information about this and how it affects our community and the families and the people who have to suffer through this, as well as Dr. Dempsey with all of his past experience and what he's doing now to educate and hopefully make some changes. So thank you, gentlemen, for joining us today. And again, just pass that mic back and forth. Just do me a favor, don't drop the mic, okay? All right, so first question, and again, up for grabs on who wants to answer, but what are the most commonly abused prescriptions?
I'm going to pass that to you because that's what you do. You see them.
So, according to the National Institute of Drug Abuse, they say opioids, depressants, and amphetamines are the 3 top. So when we look at those 3 classifications, opioids, of course, are prescribed for pain. Benzodiazepines are typically prescribed for anxiety. And the amphetamines are typically prescribed for attention deficit disorder. So right now we see an increase in college students abusing Adderall and Ritalin, right? So why are they doing that? Because there's a lot of pressure, right, in college. They want to stay up all night and study. So that is typically what a college student would testify to. So, Dr. Dempsey, any others that you?
You know, what I see a lot now is patients are on all 3. They're on a narcotic for pain, they're on a Xanax or clonazepam or one of the benzodiazepines for anxiety, and those 2 medications make them tired. So in order to stay awake, they top that off with Adderall. So I see them all on that. So they all come in, first they get their pain meds, then they want something for anxiety,
Right.
And then they're saying, I think I have attention deficit disorder. I'm really having a lot of trouble at work, and all of a sudden I see these people coming to me on all 3, and now I have to try and get them off, unfortunately. And it happened over time. Physicians, we're trying to help people, and people come to us with these problems, and we have medications that we can utilize that can be of help, and our job is to ease suffering. And so what did we do? People have a lot of pain, we gave them narcotics. People have anxiety, we gave them medications for their anxieties. And people who have ADD, who can't perform, who are having trouble at school, they have trouble at work, we gave them medications as well. Not knowing when this all started what a problem we were creating.
Correct.
Not understanding the addictions that we're going to have to deal with, And when I kid my professional colleagues, and I said, we created this problem. We're trying to help people, but we created it. We created this monster that's attacking our society now. But now we're obligated to starve it to death. And that's hard because as soon as you, and a lot of the audience has been involved with trying to get people to stop using these medications. And the anger and the hostility that creates with these patients is really, really hard to deal with. So what physicians do, I'm not dealing with her. Just give her pills and get her out of here, because I don't want to deal with her yelling at me and screaming and cursing and throwing things. When you try and get people off of these medications, they're very, very angry.
So then, because of we have a medical school here, is that something that is now incorporated or should be incorporated into their training, that this, especially we spoke earlier, Dr. Dempsey, the level of pain where people are saying, now everybody asks, years ago, you have pain, where no one even talked about it. Now that's what happens, and that's when these drugs are prescribed. So is that something that doctors are looking at through just because we happen to have them, but throughout the country or the world? Is that happening?
Well, I could speak for the 37 days I've been at the Wright Center. That I do see that. I saw the first week I was there that physicians took a pledge, the national pledge, to reduce their prescribing of opioids. I've seen that same week our physicians all register for the monitoring program in Pennsylvania. That same week, I received many calls from many of our providers on what to do with people that they've been prescribing to for, let's just say, 5 years, that now they see they're also getting prescribed from a doctor in Wilkes-Barre, and they're paying cash for that med, and they're turning the med at the right center in under their insurance. So we are definitely trying to tackle that from a physician standpoint and from a medical clinic, and I think it's a great place to start. And as far as the residents go, they're seeing our doctors because they're shadowing our doctors in the exam rooms, and they're part of witnessing the doctors assisting these people come off of these long-term prescriptions.
Because it,
What I try and do with residents, I teach residents, I say, 3 drugs do not prescribe. 1, Xanax. 2, Vicodin. 3, Percocet. Do not prescribe them. Okay, they're way too addicting. There are other medications we can treat pain and anxiety with that don't cause those problems. If by some chance that you have to because of the extenuating circumstances, only for a few days. That's it, But what happened is you'd go and get your knee operated on, they gave you a prescription for 30 Percocet. All right, so what happens to those? You take 3, I don't need these, you put them in the medicine cabinet. Your pain's controlled. Tommy finds that you got Percocet in your medicine cabinet, and he takes them. And he takes them, he shares them with his friends, and they get high. And that's part of the things we want to talk about is we have to get rid of those drugs. When they're not necessary anymore, you have to flush them. And we can't prescribe large quantities of those medications. And that's what we're trying to do. But as you said about the 1 to 10, what's your pain level,
Yeah,
10?
yeah.
I don't ask that question anymore. I say, tell me how your pain is affecting your ability to function on an everyday basis. How is that affecting? And then I decide based on their answers how to manage their pain. But it's really, really hard when they're already on them. And that's what's happening is a lot of doctors are saying, I'm not giving it to you anymore, and now they're coming to me. And they say, I said, I'm sorry, but we're not going to prescribe those for you. Number 1 is I never prescribe it the first time I see somebody. Number 2, you have to sign a pain contract. You have to have urine tests done today to make sure there's nothing in your urine. We go through a whole process. And then I say, all right, I'll take you on, but the goal, we're going to get you off these meds. If you're not willing to commit to that, then I'm not taking care of you. And that's how I try and deal with it.
we could be here for a week because my mind is spinning with stuff way off of mine, but I just want to ask this. You said earlier, Scott, that someone goes to their doctor and they do the insurance, but they go to the doctor somewhere else and pay cash. And I know this is probably a HIPAA question or a HIPAA problem. What about shared records? Is that can't happen, right, because of HIPAA? So no one knows if they've gone to another doctor?
So our shared record now is the monitoring program.
Okay.
So we
Okay.
can now go in and see, pharmacists can go in.
Yeah.
The physician's assistants could go in, the nurses could go in, the docs can go
Okay.
in. I could even go in. I'm registered to go in under a doctor. So
Okay.
I can, go in underneath them. So we can keep a good grip on our patients now, on, anyone that's possibly abusing that. So we're checking it on all that are
All
getting
right.
pain medications.
Okay, so please tell everyone, either one, what actually is an opioid?
You're the MD. So I know what it
This
is.
is what
but-
gets me upset. Opiates come from the poppy plant, okay? 80% of the poppies grown in the world today come out of Afghanistan, okay? So Afghanistan, I said, Afghanistan could defeat our country, not fire a shot. Just keep sending the heroin, sending the opiates. And then the seed pod of the poppy has opium in it. And that's where they get an opiate. That's where that comes from. And then they bring it in, as Mr. Knowles was saying, they process that in other countries, in Asia and such, and they send it to us then. Through open borders. I'm not sure how it gets in here.
Right.
But that's where it comes from. And an opiate is, anything, it's heroin for the most part. And then other, commonly prescribed drugs that come like heroin are morphine and codeine and hydrocodone and oxycodone and other ones as well, but they all come from that plant.
And the Oxycontin is the synthetic side of that.
Okay.
So, let's say man-made.
And that's
right?
the one I think so many of
Right.
them, one of the questions is, what are they? But you've just told us that, which is great. But that seems to be one of the most common.
It is.
Yeah,
It is.
okay.
It is one of the most.
So in your estimation then, if someone were to become addicted, does it depend on the person? In other words, how quickly can this happen to someone? Or again, is it up to the individual? Yeah,
I
it's
mean,
too vague to-
it's, you know, some people can be prescribed a painkiller and take it for 2 weeks and not get addicted.
Mm-hmm.
I think a lot has to do with that individual's, let's just say, history. So there's been studies out there that show that people who have depression or people who have anxiety or people who have had trauma in their life at some point are easily addicted because it fills that void or that gap. It numbs the problem.
And then what about familial? I mean, is that, would that be an issue too then, obviously, if it's
Sure.
hereditary? Okay,
Absolutely.
Okay.
I mean, I think we have to look at the disease side of addiction.
right,
Absolutely.
okay.
I'll ask my patients, a lot of it is a neurotransmitter issue in the brain. There's a physiological response that occurs when you take these drugs. The chemical mediates a neurotransmitter called dopamine, and that's inherited. How the chemical makeup of your brain is inherited, and so I'll ask them, do you have someone in your family who died of suicide? Do you have somebody who had a nervous breakdown? Do you have someone who has a history of alcoholism or drug addiction? If that is part of your family makeup, I'm very, very cautious
Yeah.
about prescribing for those family members because they are really at high risk for developing addiction.
So tell everybody out there, what are some of the warning signs that you would look for if someone is becoming or has been addicted to an opioid?
So, I always say change of behavior, right? Because even people who are in recovery or people who are what we say are abstaining, when they relapse, they always relapse behaviorally. Well, the same goes for someone who's just starting. You notice a difference in their behavior. Maybe they're shutting down. Maybe they become more depressed. Maybe they've become more irate or out of control, an increase in anger, missing work, right? Not managing monies. So I think that there's a lot of warning signs that family can recognize prior to them actually knowing that, or they find the drug, or, they end up in the emergency room. So.
Now, are they similar? We're not talking about alcohol here, but are there totally different looks of someone who's addicted to alcohol versus opioids?
Not always, no.
No.
No, I mean, addiction is addiction, or dependence is dependence. I mean,
Okay.
Everyone is different, but there are common, warning signs, as I just stated, that
Right.
would definitely be red flags for someone who is possibly, using.
Okay, so we say that these pills are coming from prescription. So if you're getting them prescribed by the doctor, then how does one become addicted if, I know what you said, earlier, Dr. Dempsey, that we'll do 30, you only need 10, you throw them, you put them in, and how does a doctor keep doing this or to keep writing the scripts? What happens? Do they go illegal ways to get it? What ends up happening with that?
Well, typically what happens, and I can tell you, the chief resident where I did my residency program ended up in rehab. And he went to get his knee operated on. And after the operation, he had Percocet, and Percocet started him down that road because he had the genetic predisposition for addiction. So there's two issues you're dealing with. One is addiction, and the other one is dependency, okay? And they're different. Dependency is someone who is not abusing the drug. They're taking the drug as it's prescribed, okay, but they can't stop taking it. I mean, every 30 days, they're there, They never miss a pill, because if they stop, what happens? Their body starts going through withdrawal, and so they can't control that. Addiction is where they start abusing the drug. They take 2, 3, 4. They're chasing that high that they can't get, and that's different, But anyone in this room, if I gave you enough Percocet, you're going to become dependent. Now, some of you will become addicted, but you'll all become dependent. Now, what does that mean? Is your pain dependent? Are you dependent? Is you physically dependent? So that's what you have to be clear on. But the withdrawal is the same. When you try and stop it, you're going to withdraw either way. And that's where the problem lies.
So both questions that I have next were sort of, you answered in it in the sense that physical addiction, someone who is abusing, or someone who has to actually take them, who does it 30 days, they go in, it's running its course. So if that's the case, then you said someone who abuses then takes 3, 4, 5 a day, or however many it is, and then they're going back. So is that then on the doctor, if this person is abusing that situation, to do some of the things you're asking, to question, to probe a little deeper into why they're doing it?
I mean, yes. I think it's part of the doctor's responsibility, to ask questions, and through the monitoring system, if we see that they're coming in to see us prior to their the prescription expiring, then we know that they're taking too many, right? So that's typically another warning sign, is that they're calling us and saying they lost them, the dog ate them, my brother took them. I mean, these are things that are just common, right, in the world of addiction.
So the dog gets blamed for everything, the homework, the pills. But so then, are there alternatives to opioids?
Yes, there are.
Like non-addictive alternatives is what I'm saying.
Right. What happens when someone becomes dependent? There's an alarm system. It started with a back pain or a knee pain. They had the pain, and then once the dependency happens, that alarm just keeps ringing. I'm in pain, I'm in pain, I'm in pain. So we have to find other medications to try and shut down that alarm system. And the two that we use, one is, the abbreviation is NSRI. You see it advertised on TV a lot. It's called Cymbalta. Yeah. It's a depressant, but it works really well to shut down that pathway. And then we combine that with seizure medications, anti-seizure medications that work together with that, like Neurontin or Lyrica, or some of the other drugs. So I've been trying to get patients who have chronic pain on those medications, and at the same time, I say, okay, now we're going to cut one of these Percocets out, another one out, another one out, another one out, and try and back it up that way. And there's other things that you use a lot for managing pain.
Right. So, we're in a world today where we actually prescribe a medication to help with addiction. It started with methadone, and it went to Suboxone, and now we have another drug called Vivitrol, which is a one-time-a-month shot. So I think, it's proven that some of these drugs actually help with pain, okay? A lot of people say to me, well, you're only substituting. You're giving someone a Vivitrol shot, or you're giving them Suboxone. Well, for some cases, that may be true, right? And we have some doctors out there who just prescribe maybe a month or two at a time, and they don't force them to go to counseling, and they're not doing a lot of follow-up with them, or they're not running a structured program. At the Right Center, we're not currently prescribing Suboxone, but we will at some point, because we were just awarded a Center of Excellence, and that is part of the requirements under a Center of Excellence, that we have to offer patients an alternative. But on the other side, I believe in other approaches. It's also proven that long-term use of opioids or painkillers increases pain, right? So we also, or worsens pain. So we want to offer them maybe physical therapy, we want to offer them yoga, we want to offer them mindfulness, we want to offer them more intense therapy, such as support groups in the community. I think that a lot of addiction has to do with one's environment, in my eyes. So if you can take people out of a bad environment or a bad situation, you have a lot better chance of making progress with them in a positive environment. So, and they'll do well. So I think there's a lot of options. There's a lot of medical options, and I think that there's a lot of therapy options.
Like holistic ways of
Yeah,
helping.
yeah. I believe in throwing the kitchen sink at them. You know, I mean, you got to have a wide array of services. You know, you have to meet patients where they're at.
Right.
We can't dictate their treatment, right? We don't know what's going to work for them, and we have to, you know, if they're committed, ask them what'll work for them. You know, we've already caught a few people who were abusing medications on the registry, and you know what? None of them were defiant or oppositional with that. They, you know, surrendered and said, "Thank you. I've been struggling with this for 14 years or
Right.
12 years, and you finally caught me." So we've gotten them inpatient. We've gotten them, you know, other options. So.
We don't want to cast them to the curb, and a lot of doctors are doing that. Just say, get out, we're not giving you any more narcotics. Well, that doesn't solve their problem. You still have a patient that's in trouble, you know, and you have to reach out to them and say, you know, we'll help you if you agree to stop using these drugs. We'll work with you to detox you. We'll work with you and deal with the problems that you're trying to self-medicate with, you know. But some of them just say no thanks and they walk out. You know, so we give them the option. Either we'll give you 30 days and go get a different doctor, or we'll help you. But it's their decision. You know, we can't make them do anything. You know, anyone who's cared for or loved people with addictions know that their sobriety is 100% their decision. Oh, we'll reach a hand out for them, but they got to take it. You know, and that's the problem we have. And what's worrying me now is a lot of these people who are stopping their prescriptions are going to the street and getting heroin.
Yeah.
That's creating another problem, and we can't let that happen either. You know, and so it's hard as a clinician to decide what are we going to do, how are we going to help these people, and that's why we are dedicated now at the Right Center to train doctors and to work with patients to deal with this epidemic.
Scott, on the behavioral side, and you may not be able to answer this, but when someone like you just described as someone who said, "Oh my," there's almost like that sense of relief, like, "Oh my God,
Right.
I know, it's out there." Do they seem to be the patients who are more apt to recover, or is there no correlation between that and someone who fights it the whole way and say, "You know, I'm not doing anything wrong"? But is there any value to any of that, or is it just a luck of the draw?
Well, yeah, I mean, I think when one surrenders, and for the AA people, John could probably, you know, definitely chime in on this, that you know, the first step is admitting that you have a
Right,
problem.
right.
Right? So taking that leap forward and saying, yes, you caught me. Yes, I surrender. That's a big step for someone. And yeah, I mean, I believe there's hope in recovery. I believe that, you know, we can help a person like that. They may have their struggles and their difficult times, but you know, it's that first step that matters in my eyes. You know?
And then what about the long-term effects of this abuse? What type of damage is associated with that?
From a medical.
Okay.
Yeah.
Well, you know, I look at heroin addicts that have been heroin addicts for a long time. You know, and you see kids now watching, you know, zombies on TV. These people become zombies. You know, there's nothing there anymore. Their soul is gone. You know, it really has that type of a devastating effect on them emotionally. And then physically, what happens is you have a limbic system in your brain that controls, you know, urges and things that make us happy and that cause addiction. And what these drugs do, many of them, is they cause a big influx of dopamine to fill that void, to fill that space. And so it heightens, you know, tremendously the good feelings that it's supposed to only be, it should be a small effect, it's a huge effect. Now, when they keep using that and flooding that system, sooner or later, the dopamine doesn't work anymore.
Yeah.
And now they just have this hole.
Depletes it.
So
Depletion.
the brain actually can't be done naturally then?
Right.
Wow.
And it takes forever to replenish that. You know, anybody in addiction knows, you know, what their brain is, they say they're wet. You know, and you have to wait till they're dry before you can make any headway. You know, you taught me that. You know about that. So you can't do anything. They're wet. You got to wait till they dry out. You know, and that's a big part of that. That brain just can't function at any level. You know.
When you talk about long-term effects, I mean, it's both physical and social, right? So, I mean, divorce,
Yeah.
wives
Loss of
leaving,
job.
kids not talking to their parents. It just wreaks havoc on a family, right? So I always say, you know, long-term is a slow death for most, you know. But, you know, until you talk to heroin addicts, and I do a lot of, I ask a lot of questions to them, because if anybody can teach me, it's not Google, it's them.
Right.
Right? So one described it to me as a relationship. It wasn't an addiction. It was a relationship. It gave them all the needs necessary in life as a positive relationship would. So that, I know that's deep, but you know, that gave me a different perspective on opioid addiction. Now, I never had someone who came in to see me with a cocaine addiction tell me that, or I can't tell you the last time that I screened someone that said, yeah, I snort cocaine. I couldn't tell you that. I haven't seen one in a long time. You know, it's all opioids and alcohol. You know, marijuana is the least of our concern right now, even though it's a problem, right?
Right.
But there's bigger problems. And, you know, in life we have to prioritize our priorities. And I think that we're dealing with some real difficult individuals who are not only facing addiction, but who have co-occurring disorders, who have compounded that with mental health, you know. And we can say, what came first, you know, the chicken or the egg? Or, you know, to me, they're both going on at the same time, and we have to treat them at the same time. You know, you can't be rational with someone who is in the height of their use, and you need to make calls to the inpatients to have them detoxed. But once they detox off of the substance, now it's time to treat both at the same time. I'm a believer in that. You know, you can't wait. You know, one doesn't trump the other.
So the reason for the frequency and all of the publicity around this is why? Why is the real reason that all of a sudden this is coming out of the woodwork, so to speak? What's the reason?
Well, the reason right now is that, and you see this publicized everywhere, there are more people dying from overdosing with prescription drugs than are dying in car accidents in our country right now. And typically what you see is, you know, and the coroners and the district attorneys could tell me this, that they die from a combination of opiates, whether it be heroin or a prescription drug like Vicodin or Percocet, benzodiazepines like Xanax, mixed with alcohol. And that combination will suppress the respiratory system and they'll die. And that's what we're seeing now. There's been enough prescriptions of Vicodin and Percocet prescribed in this country for every man, woman, and child to have their own 30-day supply.
Wow.
That's how much Vicodin and Percocet have been prescribed. Because this society that we're dealing with now doesn't want to have pain, and they don't want to have anxiety. You know, and the human condition involves pain and anxiety. There's just no way you're going to get around that. But what we've created now is a society that says, no, I shouldn't have to have pain. I want my Vicodin. Why should I be anxious? You have a pill that will take away my anxiety. I want it.
Right.
And they get it.
And that's hard. Because if you don't give it to them, it really creates
Other issues.
Between my patient and I, there's a big problem right now. And most doctors don't want that conflict in their relationships. And so it's easier for them just to keep writing it and keep writing it and keep writing it. But to sit down and have the come to Jesus talk, you know, is hard. It creates a lot of anger. There's an evil there that I perceive. You know, there's an evil there. As soon as I try and take that away, the anger comes out. They become very hostile, very confrontational, and very angry to me, you know. And I just said, I'm trying to help you. You don't understand. I have to work. I have 4 kids to take care of. If I don't have these pills, I can't support my family. And you're going to say no? You're going to just kick me to the curb? Is that what you're going to do? I deal with that every day. I deal with those conflicts every day. You know, and then, you know, it's very difficult. And we try, but, you know, it's hard as a clinician. And that's why it's very important that we have programs set up where it's not just a doctor. It's got to be a team.
Right.
It's got to be doctors, behavioral health therapists, you know, police, you know, district attorneys, you know, judges, everybody working together to try and help these people. They're not, in many cases, they're not criminals.
Right.
They're sick. You know, but sometimes you got to put them in jail. You know, sometimes jail's good because that's all you got left. You know, they won't die in jail, usually. You know?
So hopefully, tell me, that hopefully was going to be what I said, but tell me, because I'm glad I'm a novice, I know enough about it to know, but please excuse my ignorance on this.
Sure.
What about, because I had someone in my own family who died with a needle in their arm. How does it go? So help me from the pill where you would take it. What happens when it's through a needle?
So you're asking, if I could just rephrase it, you know,
Please.
how does one go from getting a back operation, right?
Right.
Maintaining a job and a family, to going down to Hazleton and buying, or Scranton, or Dixon, or wherever,
Right.
because we can buy it anywhere, to street heroin.
Right.
So I think, I mean, this is what it is. It's doctors cut them because they see them abusing it, right? So now the withdrawal is so strong, right? They usually go to snorting it. They won't, or smoking it. They won't
Inject.
immediately go to IV use, right? And then once they get introduced to IV use, it just, that's the best means for them.
Because
you
it's
know?
faster, because it's
Correct.
right into the
Yes.
bloodstream? Okay.
Yes, yeah, the best route of ingestion.
They keep
as
chasing
we
that
said.
high,
Yes.
right? They
Wow.
They chase it. So,
They chase it.
you know, and also to buy an oxycodone on the street, and I mean, don't quote me, but the last time I heard, it might be $20 or $25 for one oxycodone pill. Well, the cheapest you can buy it now, you can get it for $2 a bag in some of our local neighborhoods. And the thing that concerns us is that that's now cut, right? Like John had said and others have said, with fentanyl. And now on the Ohio border, we have the horse tranquilizer that it's being cut with. And that is even scarier, because even a first responder can touch a person who's overdosing and get a little on them, and they will immediately go into, withdrawal, or need to be administered naloxone themselves. So it's scary, right? But, you know, it takes a team, it takes the community, it takes the professionals, it takes the families to get people the help. So.
And as I said, ladies and gentlemen, we could be here for a week, right, going off on all of this stuff, because it's unbelievable to me. So then we spoke a little bit earlier about the prevention and what is being done out there for prevention. We talked about the education of the doctors now in different ways. But what would you guys say is the greatest form of education and trying to prevent and help these people going on now in our society?
Prior to?
Yeah, well, just in general,
So, I mean,
that's good.
I always feel it starts with kids.
Okay.
So I have a background in working with at-risk kids for many years, and I think that it starts in the home, right? So hug your kids a lot, tell them you love them, educate them. Don't be naive, get in their business, right? Be a part of their business. I had a parent one time tell me, well, that's their phone, and I'm not going in it. I said, well, who pays for it, right? Well, I do. Well, then why aren't you in their phone, right? So you need to be a paranoid parent. I believe in that. I believe in tough love. I believe in discipline, but I also believe in an equal amount of love. So I think when it comes to kids, you need to be there for your kids, and you need to be in their business. But you also have to educate them. A lot of parents avoid that. topic, and they don't want to talk to them about it, and they're afraid that if they talk to them about it, they're going to educate them on how to use it or where to find it. I don't believe that that's true at that age. You know, I believe you explain the dangers to them. I believe in traumatizing the kid a little bit and going on the internet and showing them some photos of people who had mug shots, and I'm still a believer in scared straight, but you know, some think it's too punitive, but it works, right, for some. But there's also, you know, a part of that we don't have control of, right? We're not with our kids all the time, and that's the scary part. But I feel that if you can do your best to educate them and be there for them, and I feel that that's where it starts, you know, in the home.
Dr. Dempsey?
Well, I think you have to educate your patients when you prescribe these. You have to educate patients when you prescribe the medications. This is a very dangerous medication. We're going to give it to you for a short time. There's a high risk of addiction and a high risk of dependency when you take it. So I don't think a lot of people understand that. And kids take prescription drugs because they say, well, how dangerous could it be? I'm not using heroin. I'm not snorting coke. It's a prescription. It's safe. I can take that. We can share that. And kids don't understand that, you know. Now kids are doing, you know, cough medicine, you know, chlorocidin, you know, because they get high from that. Because you can get over the counter, you can go and buy it. You know, you see a lot of kids doing that. We had a death in the Abingtons a couple of years ago from an overdose from cough medicine. You know, so these are things you don't even realize are potentially life-threatening to children. So we have to educate, you know. Go to schools. I mean, I talk to confirmation classes about that. You know, I give a lecture, good kids can make bad decisions, and just try to teach them about that. You know, it only takes one time in many cases, especially like with crack and cocaine. You get addicted with one exposure to that, where other drugs take longer, you know. But I lost good friends. You know, one of my friends was a chiropractor who got his knee operated on and ended up with the needle in his arm, dead in the back of a garage. You know, I mean, it's terrible. You know, and it knows there's no boundary. It doesn't matter what you're, a doctor, a lawyer, you know, whatever your position is, wherever you are in society, you're not protected. The other thing I learned too is watch your children's friends, because if you lose the kid to the friends, you lose the kid. You know. But, you know, addiction is like dropping a grenade into a family. It destroys the family. It destroys marriages. It destroys everything in a family. And that's why, you know, the drug addict, he's happy, he's high. But everybody who loves him suffers tremendously. Right. When you destroy the family, you destroy the community, and it just explodes out. And that's what we're seeing right now.
Okay.
It starts with family. And
I think it's important to know, too, that things like this that the community is doing, and again, thanks to Leah for this, the space and for getting it out there, that's going to change things too. As like you said earlier, Scott, the community and paying attention and being aware of these things in your own family will help you just pay more attention, because it is so out there. So if I had a prescription drug, and I know we just spoke about dropping off your unused drugs here in a couple weeks, that is the best way to do it. But what if a mom has 20 left, say? What does she do? Can she take them back to the doctor? Where is the easiest thing if there isn't a planned drop? What would she do to get them the heck out of the house?
So, I mean, I know locally there are many municipality police that have take-back stations. I think right here in Chinchilla, South Abington Police, I believe, has one. I know there's one in Carbondale. I would say call your police department and ask them, and they will definitely know where you can, you know, drop it off. But there are local initiatives in place for that. Some courthouses have them, but you always want to call ahead of time to see, you know, what's the closest to you. You don't want to be pulled over with someone else's prescription, you know, in your vehicle. But
some of these they tell you can flush them in the, you know, especially the dangerous ones. Things that could kill with one, like the fentanyl.
Fentanyl, yes.
You know, they want you, when you're done with it, fold it over and flush it. You know, there's a lot of things written about that, in terms of, because they say, well, is that affecting our water supply? And so everybody who takes one and pees it into the toilet is affecting your water supply. So
Right.
that's one of the issues for really dangerous ones.
Right,
Okay.
right.
The other thing they tell you, that's the ones that will kill with one tablet. When a kid took something like that, like if they took some of the stronger, like oxycodone, you gotta get rid of those. With those patches, they cut them and they suck them, and that's how a lot of them die from those. Other things what they say is to mix it with something that's not palatable. Like take the pills, put them mix them up into a baggie with coffee grounds, with kitty litter. For those of you that have dogs and you walk around your little bags around the neighborhood, toss it
Put them in there.
and then scratch all the information out on the container if you can. Put them in a bag, close it, and throw those in the garbage. But those are some of the things that I've seen recommended and how to get rid of it. Because you don't want somebody, looking in your garbage and seeing the pill with the information on it, and then start seeing if you had any medications you had left over. But the safest way is what you said. But
Yeah.
sometimes that's not available. Now what do I do?
No.
I have people say, well, I brought it back to the pharmacy, and the pharmacy said that they don't want it. What am I supposed to do?
No.
Pharmacies
that's-
don't want to be responsible for it, but I know that there is, I forget when it is, but there's national take-back events once a year. But I would suggest calling your local police and saying, here's the deal. There's a lot of Good Samaritan acts set up around that you can bring that in, whether it be your neighbors who's elderly or anyone. So.
But the best thing is to get it out of
Yes,
it, because once you're
absolutely.
pain-free and you don't need them,
Absolutely.
don't have them available for
Absolutely.
anybody else either.
What I often tell people too is that we have a lot of people who are prescribed, and I'm not going to say at the Right Center, but in other areas, painkillers for procedures that you don't need one for. At best, you may need 2 ibuprofen or 2 Tylenol. So, a lot of times, whether it be someone who maybe does a root canal on you or another in and out procedure, it's probably best not even to fill the prescription.
Right.
Unless
it
you
out.
think you're going to need it. So, a lot of people say, oh, I'll get it just in case I need it. And how many times do you really go for it? You don't, because the ibuprofen or the Aleve took care of it.
I always say it's like killing a mosquito with a bazooka.
Correct. Correct. Right. So it is overkill. And there's actually a doctor down near Williamsport who actually does a lot of pain management, and I heard him actually at the medical college say that that a lot of dental procedures are prescribed opioids that they shouldn't be prescribed for. And he said it really needs to start with, dental procedures as well. So, just keep that in mind. So.
Yeah. So I just want to let you know that the National Prescription Take Back Day initiative is Saturday here. Well, it is Saturday, October 22nd, but here at the Abington Community Library, it will be from 10 a.m. till 2 a.m. 10 till 2. How about that? A whole day into the morning. 10 a.m. till 2 p.m. Oh man, 10 a.m. to 2 p.m. It'll be available here. So please, if you have anything in your home, you don't need them, bring them here and drop them off. And it is a national day, so please know that that'll be everywhere. So I just wanted to make sure Leah so kindly dropped
Well,
this
thank
one.
you.
I was like, they know it's coming up. So again, October 22nd from 10 a.m. to 2 p.m. Yeah, I got it. Okay, so anything else, gentlemen, before we leave that we didn't cover that you think you need the audience to know, and for that matter, the viewing audience, because this will be rebroadcast on ECTV?
Everyone needs to understand how dangerous these drugs are. They serve a place, okay? They are narcotics. In most cases, should not be utilized for chronic pain management. There are situations. Most of the narcotics are used for back pain. You do not need chronic narcotics for back pain. There are other ways it could treat it: injections, medications, surgery, not chronic narcotics. Migraine headaches. No indication for narcotics for migraine headaches. There are other ways we can manage your migraine headaches. But these are the pains that people come to me with. Arthritis. There's no indication for opiates because you have a pain in your knee. Okay, it's ridiculous, but people prescribe them, because they say, well, that's the only thing that gets rid of my pain, doctor. And that's what you have to do. No, there are other ways we can manage your pain, and a little bit of pain never hurt anybody. It's part of your spiritual growth. Remember, what doesn't kill you makes you stronger.
I'll go one step further, Dr. Dempsey. It's probably because you grew up in an Irish family. We believe in that, so that's what happens. But Scott, anything on your end?
I think from a behavioral health standpoint is that, there is a lot of great services out there available for people who are struggling with addiction and for families. I think another thing that I want to say is that drugs are non-discriminatory. They don't discriminate, right? They're non-biased. So, we need everyone's help to lift the stigma of addiction and start promoting recovery. That will help individuals. When we continue to label them or sometimes even family members. I had a father not too long ago who said some really nasty things to his son out of frustration. And I think we need to think even in those situations before we speak, because it's very hurtful sometimes for an addict, and it just drives them deeper into that vicious cycle. So that's all I have to say from a behavioral health standpoint.
Okay.
Is that there is hope in recovery, and there are a lot of good people locally. Gary doing the Families Helping Families, John Knowles, offering inpatient treatment, and there are many others out there that will put their hand out to help families and help individuals. So there is no set science to addiction, right? If there was, we wouldn't be sitting here having this conversation. So I think we need to all come together to fight this epidemic, if you want to call it, or crisis. So
I think too, it's the losing that, as you were saying before, and I think it just goes along with the stigma always attached to a family with an issue.
Correct.
There are so many people that are there to help and make it better and do the best they can for your child or your whoever it is, your loved one, and use that.
Right.
Community's there to help.
it's interesting. I got a call today from an individual's wife who saw that we were in the paper with the COE, and she wanted to maybe talk to me about getting him some help. And he has a very good job, and he's afraid that people are going to find out, or people are going to know that he has a problem, right? Well, he's had this problem for quite some time, right? And that was preventing him from calling. His wife called. So that's sad to me that and if we don't get this addressed, it's going to get a lot worse for him, because many people are going to know, because you might be on the front page of the Scranton Times. So but there is still a lot of stigma that has to be lifted, and again, we need everyone's help with that. So
Okay. Well, thank you very much.
Thank you for
Again,
having
I'd like to tell you thank you to both of you, and for all of you for joining us. This has been a very informative way to get this across, and anything else we can do, let's do it, because obviously this is a big problem in our community. So thank you, gentlemen.
Thank you.
Our experts today have been Dr. William Dempsey, who practices family law, but actually was a emergency room physician for many years. And then we also have Scott Constantini, who's the Director of Behavioral Health, both at the Wright Center for Graduate Medical Education. So thank you again for all of your expertise, your kindness, and your general likability. Both of you did a great job, so thank you for that. And this has been a little different for us. As I said, we usually are doing this with the 3 of us or 4 of us, and having the audience has been nice, so thank you. And again, it was Lackawanna County Medical Society's Public Health Education Series number 5. Number 6 is coming up next month, and that will be appropriate after this on pain management. So we will talk to you. Look for it next month. Thanks for watching, everybody. I'm Laurie Cadden.